So I'm going to talk through a little bit about speech and language therapy, but really focusing on video fluoroscopy, as that's what Claire kind of suggested that you might be more interested in. So please just jump in if you've got any questions at any point. It might be actually good if someone could just jump in just to say that you can actually hear me, because I'm not entirely sure if you can. But we're going to talk through the swallow sequence, signs of aspiration, VF, risk factors for silent aspiration, a couple of the interventions we use, and then how to refer and who to. So just in terms of the swallow sequence, I'm just going to kind of run through what happens here. The black bit there is the bolus. And then basically what happens is, obviously with our babies, they're taking in the milk, and then their tongue elevates to the roof of their mouth, and they push the bolus back to the back of the mouth. So when I say bolus, I mean the milk. So they push it to the back of the mouth, and then it gets back to the back of the pharynx, and then from this point onwards, everything that happens is involuntary. Okay, so what happens is the airway closes off. So the vocal cords close over the airway. The little flap called the epiglottis comes over the airway, a bit like a bin lid, shuts it off. The whole larynx moves up and out, and as it moves out, it opens the upper esophageal sphincter. So the esophageal sphincter opens, and then as you can see, all the food goes down into the esophagus, into the stomach. And what happens when aspiration or penetration occurs is, when it's penetration, the material enters the laryngeal vestibule, but it doesn't go below the level of the vocal cord. So it just stays on top of the vocal cords, and quite often it then pops back out. However, we call it aspiration from a speech therapy perspective when the material passes below the level of the vocal cords, goes into the airway, and then potentially goes onto the lungs. So as you can see here in this picture, this just kind of illustrates aspiration going into the airway. So clinical signs of aspiration, the things that we're looking out for when we're doing our clinical assessment on the ward are coughing, kind of choking, wet, gurgly breathing, and crying during or after a feed. We might see desaturations, again, during or sometimes after a feed. We can see colour changes when feeding, so a baby might turn blue. We can see eye tearing and blinking and swallowing. So all of these kind of signs you would associate with yourself when you talk about things going down the wrong way. So if you're having a drink of fizzy Coke or something and then you start coughing and spluttering, then potentially it has gone down the wrong way, and they're the kind of signs that we're looking for with our babies. But sometimes aspiration is silent and you can't see any signs. They're silently aspirating away and you don't know. And this is quite popular. This is quite common in our population with regards to neonates. And so other signs that we'll be looking out for in terms of our neonates are temperature spikes, an increase in oxygen requirements, maybe during feeding or immediately after feeding, or maybe they're just finding it difficult to wean off the oxygen. They might have unexplained desaturations and apneas during or immediately after the feeds, and they may also be getting regular chest infections. And when you do a chest x-ray, if it's on the right upper lobe, then we often think that that's kind of indicative of aspiration, but it's not exclusively there. So moving on to the swallow, video fluoroscopy swallow. So when a baby needs a video fluoroscopy, usually what's happened is they've had a clinical assessment from the speech and language therapist, and then we might suggest that a video fluoroscopy might be indicated in order to gain a better understanding of the swallow. So it's not always needed, but sometimes if we feel like this would help to get more information, then we might use a video fluoroscopy. Then that would be arranged, so requested by the medical teams on EPR. And so they would order that on EPR, and then we do fixed clinics. So we have a fixed clinic on a Wednesday morning and a Friday morning, and we have one inpatient slot. So usually there's 2 inpatient slots a week. Okay, so basically, like I said before, it's on a Wednesday and a Friday morning, although given the current kind of climate, there's a little bit of flexibility with that, and we are able to do some more kind of clinics. So if there's a real urgent need for one, then we can squeeze them in a bit earlier given the current climate. But basically, the pros of a video fluoroscopy is that it's an instrumental assessment. It detects silent aspiration, which we can't do during kind of a clinical assessment. It's got visual images, which quite often help kind of support parental understanding if they're not really understanding what we mean by aspiration and what that means. Seeing the images on the computer screen can be quite powerful, and it can really help parents in terms of kind of understanding what's going on and kind of accepting the recommendations and the plans. It gives information about nasopharyngeal reflux, which we can't necessarily see on clinical assessment. We look at esophageal transit, although we're really only looking at the top part of the esophagus, not further down. And we can see residue that we can't necessarily see on clinical assessment. And it can confirm our findings from clinical assessment as well. The negatives are obviously that it's radiation exposure. It's a snapshot in time. So just because they feed that way during the video fluoroscopy on that Wednesday morning at 11 o'clock doesn't necessarily mean that they feed like that all the time. And we bear that in mind when we're doing the video fluoroscopy. It's not a typical feeding environment. We're in the X-ray fluoro room. So they're often kind of maybe in different position, different environment, different rooms, somebody else might be feeding them, and so all of these things can impact on the baby's state and therefore on their feeding. We might have some difficulty with compliance as a result if the baby's really kind of stressed in being in that room or for whatever reason. Then so we were on the negatives, weren't we? So it's not a typical feeding environment. You might have some difficulties with compliance. Contrast is added to the milk, so that can often change the flavour. Not so much of an issue with the little ones, but it can be more of a difficulty with older children. And obviously it can be very stressful for the family kind of in general. And when we've done the video fluoroscopy, what usually happens is that we will kind of put the information on Badgernet with what happened, what the results were, and what our plan is, and then a full, more detailed report will follow. Okay, so but what's the main thing is to say is that we as speech therapists organise this. So even though we ask that you request it on EPR, we need to kind of check that it's appropriate and organise it with radiology. So sometimes, you know, we've turned up to the unit before and they've said, oh, they've got a video fluoroscopy today, and we know that that's not the case. So I don't know, sometimes there can be wires kind of crossed in terms of that. But anyway, I'm going to see if I can share this, and then if not, then we'll just have to see. Okay, honestly, right, okay, I'm just going to have to show you here, I think. So this baby had low tone, no diagnosis, and they were fully orally feeding. So we took them to video fluoroscopy, and I don't know if you can see this here, but it shows significant silent aspiration. They were really disorganized and also had nasopharyngeal reflux. So there, the aspiration is quite marked, and that was kind of a typical low tone baby, like I say, no diagnosis. And the reason we show you that is because quite often babies who have low tone, like for example, trisomy 21, they have an increased risk of silent aspiration. When we take them to video fluoroscopy, if they have trisomy 21, they quite often do have silent aspiration. And so we're really keen to get involved with these babies because we know that they're at risk. And obviously we also know that further down the line, they're also at risk of speech language communication needs, which obviously will also need speech and language therapy input. Other babies that are also at risk of silent aspiration are those that have had surgery involving the aortic arch or the subclavian artery, because this carries a risk to damage to the recurrent laryngeal nerve, and that innervates the larynx. And as a result, we know that they then can have vocal cord palsy, which means that they're at risk of silent aspiration, because I told you kind of at the beginning when we were looking at the swallow sequence, when we're kind of protecting our airway, what happens is the vocal cords close, the epiglottis comes over the airway, and then the esophageal sphincter opens. And if the vocal cords can't close, then obviously they're partly open and the food and drink can get down into the airway and cause aspiration. And then we also know that those that have been kind of post-extubation dysphagia. So if they've been intubated for a particularly long time, then again, they're also at risk of silent aspiration. And I just wanted to kind of show that for every here, this kind of reference at the bottom, which says for every hour of intubation, the odds of post-extubation dysphagia increases by 1.7%, which I think is quite marked. These references all refer to adult studies, but I think, you know, we can assume some kind of carryover into the infant population. So the different types of interventions that we do as speech and language therapists is desensitization. For example, if we've had an infant that's been intubated for a really long time and they've not had anything around their face and mouth other than negativity, so intubation, NG tubes, etc., then we can do desensitization so that they're having positive touch around the face and mouth, so that when they're ready for oral feeding, we'll be able to progress this quicker, because quite often when these babies have been intubated or had multiple NGs, etc., they can be quite defensive around their face and mouth. So we get involved for that. Obviously, oral cares we get involved in, particularly those who've been, again, intubated for a long time and they're not having kind of milk, which we know can keep the mouth nice and clean, particularly breast milk. We can do oral cares. There's a mouth care guideline which you can find on the intranet. And then we obviously support in developing oral skills through non-nutritive sucking, suck training, etc. We look at different positionings to help support, and one of the ones that we quite often use is elevated side lying, because we know that has a protective factor in it. So we often put the babies on the side, and that can help protect against aspiration. And then we might change the utensil in terms of the shape of the teat, whether or not it's a wide base, a narrow base, and different flows, fast, medium, slow flow teats. And then we also have texture modification. On the neonatal unit, we use Cowan Gate, as it's the only one that's licensed for under ones. It's worth saying that some people say, oh, well, they've got Gaviscon in their feed and it's already thick. Gaviscon isn't enough. It quite often needs to kind of be more thick than that. And the IDDSI is an international kind of classification that looks at the different consistencies, and it goes like from 1 all the way up to 7. And we quite often start on 1 with our infants and obviously work up from there. But like I say, yeah, we use the Cowan Gate Carabel, but it's worth saying if an infant is on Gaviscon, then that needs to stop, because we know that Gaviscon and Carabel are contraindicative and they shouldn't be used together. So that's why we request that if a baby is on Carabel, and if we ask for a baby to be on Carabel, we will ask that you list it on MedChart. And then pacing is also used, where we kind of we'll feed the baby and then we'll give them a pause of a couple of seconds and then feed them again, just to kind of slow down their pace and help protect their airway. We do sometimes put infants nil orally, but we would only do that if there was no other kind of safe oral feeding option. It's not something we do a lot. So post airway surgery, so this baby had a VF following airway surgery, and this was on a medium flow teat, and hopefully you can see that they did aspirate. It's very, very small. I'm just going to try. Okay, it's not letting me, sorry. So this one is 11. So this is the same patient, but we put them on a slower flow teat. So we didn't see any aspiration, but they weren't as efficient. So you can see here, they're taking lots of sucks in order to get a small kind of bolus to swallow. And so whilst there's no aspiration, which is great, it's not ideal, because they're kind of working too hard and they're going to really burn off all the calories that they're going to get from all of the sucking that they're doing. So it's not ideal. This next one is a preterm or an ex-prem baby post-extubation, and they were being externally paced. You can see here. So external pace, which was saying is though, let them feed, feeding there, and then we will stop them. So you can see there's no milk in the teat there. We stop them getting the milk, then we go again, and then we'll stop them getting any milk, just to kind of slow them down. And we didn't see any aspiration there, so that was really good. This is the same baby that we videoed, and they didn't have any pacing at all, so we just let the baby go for it. And as you can see, they become a little bit more disorganized. They're struggling a little bit more. you can see that they're probably about to aspirate. They are struggling. And then there you see there's a tiny little bit, you can see a little black shadow in the trachea. So again, it's just to show that some of the therapeutic tools that we use, such as pacing, really have significant kind of impacts. And so if we put pacing in the plan, we're really keen that the parents and the staff are following those guidelines, because we know that it can help with the infant. So this one is a baby that had vocal cord palsy, a trachea, and they had thickened fluids to what's called the IDDSI level 1 consistency. I don't know if you can see, but there was quite marked aspiration there. So I'll just point it out to you. There. So what we did is we thickened it to an IDDSI level 2, so it's a little bit thicker, and we didn't see any aspiration or penetration then when we tried this, which was great. So they just needed it to be a little thicker, and what thickening does is it means that it slows down the rate that the fluid flows, so they've got more time to close off their airway and protect themselves. Now, it's great that this baby was able to kind of feed with a thicker IDDSI level 2 consistency, and they were quite efficient. They're able to get it out of the teat nicely, which is great. This isn't always the case. Sometimes we might need it to be a bit thicker, but in being thicker, they're not as efficient and they're not able to extract the milk from the teat as easily, and therefore it can be a little bit tricky in terms of getting the balance right. So this one is a baby that had hypoplastic left heart, and they had vocal cord palsy, left vocal cord palsy. And what we did is we tried to replicate the medicine given from a syringe. So baby was having medicine from a syringe, and we tried to replicate that in the video fluoroscopy to see whether or not they were going to aspirate the medicine. And as you can see, they do aspirate the medicine. A little bit there. It's really difficult to see, and I'm really sorry. I don't know why it's not letting me share these pictures. I'm having such a mare with these today. But I could maybe share them with the group, and then you could look through them in your own convenience if you were really interested. So just then to talk about our referral system. So you can bleep to talk to us about any referral that you're considering, and we can have a chat. But if you want to formally refer, we need an EPR referral. So if you just go onto the baby's kind of name on EPR and then go to orders and then type in speech and language therapy, then pediatric speech and language therapy referral will come up, and just fill out all of the things that are starred. We've got a 48-hour response time, so we aim to see a baby within 48 hours of receiving the referral. We see babies that are needing lots of suctioning, not managing their secretions, baby who's aren't able to elicit a rhythmical suck, maybe having some impact on their feeding reflexes, so the suck and their rooting reflexes, babies that are coughing and choking with feeds, babies that are consistently desatting with feeds, they might have stridor or respiratory distress during or after feeds, babies that have conditions that mean that they're at risk of silent aspiration, like we talked about earlier, so those with trisomy 21, vocal cord palsy, who are post-extubation, babies who are inefficient with their sucking or feeding, falling asleep during feeds, babies who've been ventilated for a long time, and babies who are nil orally for extended times in order to kind of reintroduce it. And we see all babies that have tracheostomies. So myself and Maya are the main therapists on the neonatal unit. You might see a couple of others up there as well, but we're the ones that are there most of the time. And just that's our information if you wanted to talk to us about any of the patients.